Welcome to our arterial blood gas lesson. This is going to have a couple parts to it because we're really going to break down the ABG or the arterial blood gas to the fullest extent, because this can be one of the most overwhelming and confusing topics that people face, not only in the classroom, but also at the bedside as well. So when we think of an arterial blood gas, it is exactly that. It's taking blood from an artery. And when we get these lab results back, they can be a little confusing of what all they're telling us, because this is an indication if our patient is in some kind of acidotic state or alkalotic state, so either acidic or basic. However, there are two ways or two mechanisms that our patients go into this. It can be either respiratory or metabolic. So a lot of times when we're looking up acid-base imbalance, we might see that graphic that says respiratory acidosis looks like if this level's up or this level's down, then you know you're in it. No more of that memorization. This video is going to break everything down so that way you really understand what exactly an acid-base imbalance even means, and you'll know exactly what state they're in by interpreting these labs. My pages might look a little different than yours if you're following along in the Nurse Workbook 2.0, because we're constantly upgrading our content. And so that way you're getting it here on RekPlay first, the newest, best content. You can go ahead and reprint these pages below so you can always test your knowledge and always come back and retest yourself again later. So let's get started. First, we want to obtain that ABG, or this arterial blood gas. And how are we going to do this? Well, if we don't have an arterial line already present in our patient, then we need to get it from an artery. Usually this is going to be obtained by a respiratory therapist. Some facilities, they have nurses that are certified or trained that they can achieve or obtain these specimens, but a lot of facilities do not allow nursing to do this. But since this is RekPlay, we're still going to talk about how we get this specimen and what does that really look like. So first, we're going to obtain this specimen if we don't have that art line in the wrist. And this is normally our number one spot. If we can't get it here, we can try the other side. And if we can't get it in one of these locations, we're gonna have to grab a doctor so they can either do a art stick that's gonna be femoral, or they could even put in a line so that way we do have some kind of arterial line. So how do we get this in the wrist? Well, we remember that our ulnar artery is here at our pinky. We also have our radial artery that is here at the thumb. So when we look at our landmarks right here, these two stars, both of these are important because we do something before we do this art stick called the Allen test. So this is actually known as a collateral circulation test. So what we're going to do is we're going to occlude both the radial and ulnar arteries with our fingers. So this can be when the patient has their arm over the bed or sitting on the bed. We're going to take their wrist and we're going to squeeze onto these arteries and try to occlude them, stop that blood flow. We're going to tell our patient to pump his or her fist if they're conscious, and then we're going to wait for their hand to turn pale. When their hand turns pale, we're going to release that ulnar artery side, and we're going to watch for the return of color and warmth to come back. If we see this color coming back at a very reasonable time, that cap refill looks good, this means that we have a good collateral circulation test, or a positive, happy Allen test. If we don't have good blood return back, then we should definitely investigate if the other side is potentially better. So a pass on the Allen test means good collateral circulation. It is safe to do our radial sample. And if this patient fails our collateral circulation test, and then we're gonna look for that alternate site. Okay, great. So we have gotten our arterial blood sample. So this is either gonna be transferred into a heparinized syringe, or it can be obtained with a heparinized syringe. Once we have it transferred into the syringe, or if it's already in there, we wanna make sure that we take all of the air out of the syringe and then put our cap on it. If we are handing this off to RT, our respiratory therapist, sometimes they can take this to a unit or an area in your unit, or some place where they can run this blood gas pretty quickly. In other facilities, we're going to be sending this down on ice. But first, before we even hand off this arterial blood gas sample, there's something that we want to make sure we document on our patient's label. So we have our patient's label here. We want to make sure that we're writing down the time that we obtain this sample, but we also want to make sure we're noting the temperature of the patient. In addition, we're going to write down the amount of oxygen that our patient is on during the collection of our sample. And in some facilities or some RTs or some units, we also want to write down our SpO2 as well. And we're going to talk about why it is that we need to put this stuff on the label. So there are certain times that we want to collect this arterial blood gas sample. Maybe it's before they went on the ventilator or before they're on BiPAP. And then we want to take it again once they're on the ventilator or on BiPAP so we can see what this blood gas is doing. But we're gonna talk more about why we're writing this stuff down in just a second. And then once we have this written on our label, if we're sending this to pharmacy, typically want to put this on ice. This is also going to vary by department. So what are the labs that we're gonna see on an arterial blood gas report? Well, this is gonna tell us the efficiency of the lungs, the gas exchange that's going on. So we're breathing in that oxygen and we're exhaling the carbon dioxide. So if we remember from our other lessons, this diffusion that's going on. In addition, it's also going to tell us what's going on in our bloodstream and how much potential bicarb is inside our bloodstream. Since bicarb is a buffer, this can help us be less acidic or it can help us be more basic depending on what way this goes. So our ABG is going to give us a holistic picture of if we're in an acidotic or alkalotic state, or maybe we're neutral and we're in a healthy homeostasis. And is this being done respiratory wise or metabolic wise, which we are going to get into now. So first, we want to remember what our pH is. A pH is going to measure the concentration of hydrogen ions in a solution. So normally a pH scale is from 0 to 14, and 7 is going to be our neutral mark. Anything below 7 is going to be acidic, and anything above 7 is going to be basic. But in the human body, this is different. Okay, so in an ABG, we're gonna look at that pH, which is going to be a normal range of 7.35 to 7.45. So this number is coming from a complicated negative algorithm equation. So anything less than 7.35 is going to be acidic. Anything greater than our 7.5 is going to be basic. So really, that is the basics that we need to know about pH in the human body. And our HCO3 over here, this is our bicarbonate. And bicarbonate is an alkaline substance. This is regulated mainly by the kidneys, and this is going to be a lot slower in its regulation than in our lungs, which we're going to get to. So bicarb is going to help cancel out acid. So if we think about our bicarb range, 22 to 26 is going to be our normal bicarb range. Anything below 22 going to be more acidic because there's less bicarb present. Anything above our 26 is going to be basic because there's going to be a lot more bicarb that's going to be present in the bloodstream. Then we have our PaCO2. This is the partial pressure of carbon dioxide in arterial blood. This is an acid gas that's regulated by the lungs, and this is responding quickly to maintain homeostasis. So a typical PaCO2 is going to be 35 to 45. If we think about in our bicarb situation, if we don't have a lot of bicarb, then someone's more acidic. If we have more bicarb, they're more basic. Well, with our carbon dioxide, our PaCO2, the more carbon dioxide we have, the more acidic somebody's going to be. And the less PaCO2 or the less carbon dioxide we have, the more basic someone is going to be. Since this is something regulated by the lungs, so think about it, we're breathing in oxygen, we're exhaling that CO2. So if we do this quickly, then we can help either retain CO2 or we can blow off CO2. So our lungs are able to kind of control this in a much faster way than our kidneys are by doing this metabolically or filtering this bicarb out of the bloodstream. Moving on, we have our PaO2. This is the partial pressure of oxygen in arterial blood. So normally, we want to see a range of 80 to 100 oxygenation inside the human body. But anything that's below 60, we're going to consider this hypoxia. Typically, we will even from 70s and below that as well. So here's why it's important that we want to write on our patient label how much oxygen a patient's getting or what they're even maybe statting at in that SpO2, because this is also going to let us know, are we pushing a lot of oxygen in there already that they're at this 99 PaO2, or have we not given this patient much oxygen at all and they're sitting there at that 68 or 70 mark? So then when we put them on the ventilator, we can note how much oxygen we've given them and we can see if this number is also effective or not. And lastly, we have this thing called base excess. This is the relative amount of base or bicarb that is in our blood. So we see here this -2 to +2 is that happy range. So -2, -1, 0, +1, +2, that is our normal base excess range. So the higher the number, that's going to mean more base or more bicarb. And the lower the number is going to be less base or less bicarb. So a positive base is going to indicate that there is metabolic alkalosis present, and a negative base is going to indicate metabolic acidosis. So the difference between getting that HCO3 and the base excess really is that the HCO3 or that bicarbonate is telling us the measurement in the blood of if it's below or above the 22 or 26. But that base excess is really doing this more complicated equation, saying that for this person or this situation, is there more bicarb that it's seeing in that bloodstream or less? So if your base excess is in that normal range, we don't normally think of it too much, but it is a really great indicator to help point us if this is more metabolic than it is respiratory. So time to dive a little deeper into our acid-base imbalances and how we're pointing out which kind it is. So this page might look a little bit different than yours, so feel free to print that out below and you can come back and test yourself. So if we look here, let's do a quick refresher. Our normal pH range is going to be from 7.35 to 7.45. And we know that anything below 7.35 is acidosis, and anything above 7.45 is our alkalosis. So a normal acid-base pH balance is going to be between this 7.35 to 7.45. If a patient gets critically sick, their body may leave this normal pH range. So acidosis or alkalosis is caused by one of two mechanisms. This can be respiratory, and remember, we want to think our breathing, and we measure this through that carbon dioxide, that PaCO2. Or the other mechanism can be our metabolic, and this we want to think kidneys. And how do we measure this? This is through our bicarbonate, that HCO3. So we're going to jump back to this respiratory section and really focus in all about how the lungs are regulating this acidosis or alkalosis through this PaCO2 or carbon dioxide. So PaCO2 on that pH scale, if we remember, our range is going to be from 35 to 45. So why do I have this flipped here? It's not that clean low number to high number. Well, if we remember, anything above our 45 is acidosis, and anything below 35 is going to be our alkalosis. So our pH is flipped. Those two numbers are flipped because the more carbon dioxide we have, the more acidic a patient's going to be. And when our PaCO2 is not within normal limits, typically our body's going to respond in one of two ways. It's either going to do hyperventilating, or we're going to do hypoventilating. We can control this through our respiratory equipment, or the patient might even be doing this on their own terms because it's constantly trying to find that homeostasis. So anything that causes hypoventilation means we're not getting rid of carbon dioxide properly. And as the CO2 builds up, then our acidosis is going to occur. So if we think of hypoventilation, we're going to think of how we're not actually exhaling very good carbon dioxide out. So that means that we're going to be retaining it. So if we're taking a lot of air in, the oxygen, but we're not blowing it off, then we're going to have that retention of CO2. So what could cause hypoventilation? Well, we could see this in respiratory depression, maybe in a drug overdose, a head injury with sedation, a spinal cord injury, and so on. We can also see this in lung conditions, and that's that classic COPD. And then we see it in pneumonia and potentially trauma. So remember in COPD that they are retaining a ton of carbon dioxide. So that's why we don't want to go ahead and flood them with oxygen. We never want to turn their oxygen up a lot. CO2 also triggers us to breathe deeper. So our COPD patients, remember, we're going to see them at a lower SpO2 as well, which is totally fine because since they're retaining CO2, we don't want to go ahead and push that O2 in there. With our hyperventilation, we're going to see exhaling of CO2, a lot of that. So anything that causes hyperventilation will expel too much carbon dioxide, and this is going to lose carbon dioxide, is going to result in that alkalosis. So what are causes of hyperventilation? This can be from anxiety or pain, maybe stimulants, and this is both hypo and hyperventilation potentially. These can also be related to our vent settings, our mechanical ventilation settings. So now we're going to jump over to our metabolic or our kidneys and that whole bicarb. Bicarb on the pH scale, we're going to see a normal range, or this HCO3 range, of 22 to 26. And so we remember anything below a 22 is acidosis, anything above a 26 is alkalosis. So the more bicarbonate, the more basic. When our bicarbonate is not within normal limits, then we're going to see our body be either that metabolic acidosis or metabolic alkalosis. So bicarb and acid can be lost, gained, or accumulated systemically, but this is especially through the kidneys. So metabolic acidosis or alkalosis involves more than one system, and this can affect many things. So in metabolic acidosis, when our bicarb is below 22, and our pH is going to be below that 7.35. So in metabolic acidosis, let's think about this. We just said it, but our bicarb, it is below 22, meaning we don't have a lot of bicarb present in our bloodstream. And on our pH scale, anything below our 7.35 is acidotic. So we have a metabolic acidosis. Well, how do we lose bicarb, or why wouldn't we see a lot of bicarb? This can be typically from like a severe diarrhea situation. We can even see this when patients have an ileostomy and they're kind of dumping into this bag. Ways we can gain acid. This can be in that diabetic ketoacidosis, or we can also have this in our lactic acidosis. So remember that a byproduct of metabolism is going to be acid. So, or even that carbon dioxide. So this can also be a way that we are gaining acid. And in our metabolic alkalosis, how would we interpret this on our ABG? So when our bicarb is above 26 and our pH is above our 7.45. So ways that we can gain bicarb in a situation like this can be an excessive bicarb administration, which we can do in the hospital, or even overuse of antacids. So if people are taking a ton of Tums or things to help control that acid in their belly, they can actually end up having too much of it. And ways we can lose acid is going to be through vomiting, any gastric secretions, and potentially even diuretics that we can excrete in the urine. And before we go, we're going to do a quick fill in the blank. So an arterial blood gas is drawn by usually a respiratory therapist from the patient's artery. And typically this is drawn from the wrist, but this can be done from the groin or any arterial line if it is present. This concludes our ABG lesson. I will see you in the next one.